Good evening, everyone, and welcome to another hour of Healthy Conclusions, where we try to give our listeners important information on nutrition, exercise, and holistic alternative and integrative medicine. Please take a minute to visit our website at www.healthyconclusions.com and like us on Facebook. My name is Bob Neugebauer, and I will be your host for this evening's show. Tonight's show is being brought to you by Altrua Health Share, which has been serving its members and their families with their health care needs since 1997. Please take a moment to visit their website at altruahealthshare.org or call 888-244-3839 to see just what Altrua Health Share can offer for your family's health care needs. It could mean substantial savings to you and your family. Our guest for this evening is Dr. John Livingston, a retired surgeon in Boise, Idaho, who is affiliated with multiple hospitals in the area, including St. Alphonsus Regional Medical Center and Treasure Valley Hospital. He received his medical degree from Ohio State University College of Medicine, and John has been a good friend for many years, so we're happy to have him back to discuss Medicaid this evening, Part 2. We did the last one last week. So, Dr. Livingston, good evening, and welcome again to our show. I believe the last time we left off discussing the good and bad of expanding Medicaid in Idaho, so I'd like to finish up that discussion tonight. To start off, I would like to read an excerpt from Governor Otter's State of the State speech. So, in my last legislative session, as your governor, I'm making one final attempt. No longer should this body use my agreement not to act alone on Obamacare issues as a way to stop progress that will benefit Idaho citizens. We can no longer wait for Congress. This issue is too pressing, and it's in our hands. Now, it appears that our governor has decided that it's okay to spend taxpayer money to the tune of $28.8 million on subsidizing insurance premiums for people on the Idaho Health Care Exchange, or as he calls it, stabilizing Idaho's health insurance market for working Idaho families so that they can afford insurance coverage. Shouldn't he have thought about that in 2014 when they instituted the Health Care Exchange and over 50,000 people lost their policies and premiums skyrocketed?
Well, thank you, Robert, for letting me come back. And this is an issue that is very near and dear to my heart. In fact, I was up until 3 o'clock last evening working on it. I was most concerned when, let me start out. The governor has been a near and dear friend of mine for over 40 years. And I've seen him in situations when life has been tough, difficult family situations, and the near death of his best friend. And I've seen him stand by and be a husband and a father and a friend. And he is at his best when things are at its worst. But that being said, I became very concerned when I listened to his State of the State address, and he said that as he was growing older, he was becoming more convinced that there was a place in government for taking care of many of these neighborhood, individual, family, human problems. That concerned me very much. And then when he used the words compassionate conservative, I became even more concerned. I had thoughts about No Child Left Behind and faith-based initiatives, which have just been a terribly difficult situation. So with Medicaid expansion, the conservatives traditionally have allowed more liberal people to take what they believe to be the moral high ground. They say we want to take care of poor people with government money. Actually, what they're saying is we want to take care of those on the margin with money of other people, not our own money, not our own charitable contributions, but we want to redistribute that money to a certain segment of society. We know in our state that there are between 2,000 and 10,000 people who, through no fault of their own, cannot work, have chronic diseases, will need to be taken care of for almost in perpetuity as far as their lives are concerned. These, at the most, are about 10,000 people in our state. What the governor's 1132 and 1332 and 1115 waivers try to accomplish is an insurance arbitrage. We're taking care of healthy people. The premium costs of taking care of healthy people, by the way, those premiums are paid for by the taxpayers, will offset the costs of taking care of those people, those 10,000 people. That's not what is supposed to happen. I do not believe, and I like to consider myself to be a thoughtful Christian man, I find nowhere in the Bible where it says that the government should be the conduit for charity. Charity is an individual transaction. And in fact, there are three parties to the transaction: the giver, the receiver, and God. When the government becomes involved in the transaction, it no longer becomes charity. And my feeling about my liberal friends is they think they are providing charity to a group of people that need help. I don't deny that they need help, but it's not charity. It's not their money. And I can decide better what to do and how to take care of poor people than the government can. I'm told by many politicians that this is a complex problem, and I agree with them. And the more complex a problem is, the less the government should be involved. I know I've run many complex businesses, 6 to be exact. And the more complex the business, the more likely the free market will have solutions to the many transactions that occur just to run that business. If you have a single government entity like the Department of Health and Welfare or CMS at the federal level or HHS at the federal level, it will be a mess. And the promise of Obamacare was threefold. Number one, they said they would bend the cost curve. They have not done that. They have done the opposite. Costs before Obamacare, as part of GDP for healthcare, was 17%. Today it's 22%. They said they were going to provide insurance for everyone. We started off with 50 million uninsured people. We now have 30 million uninsured people. 10 million have become insured on the exchanges, 10 million through Medicaid expansion. That's another interesting issue. Most of those people, at least 50% of those people, have become uninsured not because of the exchanges or Medicaid expansion. They've become insured because they have a job now. When the unemployment rate was 9.8%, they didn't have a job and they didn't have insurance. Now they have a job. Now they have insurance. So the governor's plan is a top-down, vertically integrated march towards socialized medicine, specifically the SHIP program. The SHIP program is really based after the provincial system in Canada, where the healthcare system is run by the provinces. The SHIP program is single-payer medicine run by the state of Idaho through the Department of Health and Welfare. This is going to hurt those 10,000 people who, through no fault of their own, have a chronic disease and cannot take care of themselves. Why? Because when the government subsidies and tax credits from the feds dry up, they will be the ones that will be affected, not the healthy people who the arbitrage system is supposedly taking care of. The governor's Medicaid expansion plan is nothing more than a subsidy to the large insurance carriers and the large providers. It does not help poor people who can't take care of themselves.
John, that was a pretty good explanation, and it's very much what my thinking is. The taxpayers of Idaho pay about $500 million a year for our share of Medicaid. Is it really necessary to throw more money away on subsidizing policies and making the insurance companies richer? You know, what happened to all of the $600 million in reserves that they had tucked away that was in the paper and spread all over the place? Where did that money go?
Wow. Well, for one thing, if you look at the exchange, which I'm a member of the board, and we've had that discussion before, it would be my hope that we should be moving toward a free market solution to health care insurance. And the alternative Medicaid expansion bill being offered on Monday by Representative Zollinger does just that. But most of the subsidies this year, at least 80% of the 80% of people receiving subsidies on the exchange are paid for by taxpayers. And there's a large number of those people, probably over 50%, that don't have to pay any premium at all, none. So they're getting free health insurance. Who's the beneficiary of that? The insurance carriers and the large providers.
John, we're going to have to take a quick break. We'll be back in a few minutes. You're listening to Health Conclusions, brought to you by Altrua Health Share, with your host Bob Nugabar on 580 KIDO AM and 107.5 FM. Welcome back to Health Conclusions on 580 KIDO AM and 107.5 FM. We're speaking with Dr. John Livingston, sponsored by Altrua Health Share, and our subject is Medicaid and why we should expand it or why we shouldn't expand it. So, Doctor, the governor states that he is not expanding Medicaid, and what it's doing is providing working families who have modest incomes with more affordable ways to get the coverage they need. Why are we not opening up immediately competition from out of state for insurance companies to come in here? Why does the taxpayer always get stuck for the mistakes of government? And what do you tell the people who are paying almost 1/3 of their incomes to pay for premiums to keep their families insured that are not on the exchange?
So, a lot of questions there, but the problem with the governor's plan was it was developed over the spring and summer by an interims committee, not appointed by the legislature, which everything is perfectly legal, but they decided to come up with two waiver requests from the federal government. One's called an 1115 waiver, which provides for taking care of poor people and making provisions that they can be included in Medicaid. And then the 1332 waiver, and the two work together, is to provide for an expansion of the APTC insurance market. The idea being that those who are going to be insured in that gap between 100% and 136% of the federal poverty level are going to be receiving tax credits. So the governor's right when he says we're not expanding Medicaid. We're not expanding Medicaid from the bottom up. We're providing tax credits from that 136 on down to the 100%. So we're expanding Medicaid from the top down, not from the bottom up.
Is there any difference?
No. And in fact, most of those people will be receiving subsidies, advanced premium tax credits, that will pay for 100% of their premiums. And they're being paid for by taxpayers who see their own premiums go up and who are paying large amounts of their take-home pay, especially if they're in the individual market, to cover their health insurance. Now, the interesting thing is that I ran the numbers last night, and at the most, we're talking about 10,000 people. If we provided 10,000 people who can't provide for themselves with a $10,000 health insurance policy, that would cost $100 million. Now, the state of Idaho has put up $28.8 million for subsidizing insurance premiums for people in the market. But actually that number is a full $100 million because the feds match that with $70 million. So we're not talking about $30 million. We're talking about $100 million.
And it's still coming out of our pockets.
And it's still coming out of our pockets. Now, there's two important points. And I know our government, our governor and his attorneys and his advisors dotted the I's and crossed the T's. But in the legislation, in the Affordable Care Act, it says that the waivers can be asked for only after they're approved by the state legislature. Now, it's my feeling that maybe the governor asked for these waivers with an executive order. If that's the case, I guess it must be legal, but it's certainly not the spirit of the law. The second point about that is that we can still, through the legislative process, which I think is the way to go, develop our own Medicaid expansion plan and pass it in the legislature, and then ask for the waiver from the government, from the federal government. That's the way I think it should be done. The other question I have is about the business side and the way the two programs, the Medicaid expansion and the SHIP program, match. It seems to me that the SHIP program also required a waiver, and I don't know. I think it had to probably be an 1115 waiver that I don't think the legislature ever saw. I know the legislature has never voted on that, and maybe that too was accomplished with an executive order that's legal. But I have talked to many people in the legislature that don't even know the SHIP program exists. And actually, it's been granted $45 million of federal funds, $18 million that have already been spent. And the question I have to ask is, after spending $18 million, how many patients is the SHIP program taking care of? Are there any patients right now in Idaho that are being taken care of by the SHIP program, and the program's already spent $18 million?
Now, can you explain what the SHIP program is?
It's the State Health Insurance Plan, and it's a vertically integrated plan through the Department of Health and Welfare that provides, that incentivizes providers to take on capitated patients in exchange for providing data and information that will, it's peer review and morbidity and mortality data that supposedly is to improve their practice patterns over time. If you meet certain benchmarks regarding your morbidity and mortality, you will be incentivized to the tune of 5% more.
Is this result-oriented?
It's supposed to be result-oriented, but the problem that I have with it is one we talked about last week, and that is people participating in the SHIP program will be less likely to take on sick patients, less likely to take on any of the 10,000 people we were talking about.
Because they don't want to have bad records.
Because they don't want to have bad outcomes. So the very people that need to be taken care of
not going to get taken care
are
of.
not going to be taken. Here's a great example. Say you're in Emmett, Idaho, and there's 4 family practitioners in Emmett, Idaho, all taking care of their own patients. Some of them are employed by large hospital systems. Some of them are self-employed. And each has 4,000 patients, and each makes about $250,000 a year. Now, one of them decides to take on, to sign up for the SHIP program, in which he will get $35 per month to take care of a set amount of patients. All he has to do is take care of 1,000 patients instead of 4,000 patients, and he'll make the same amount of money taking care of 1,000 patients as he was last year taking care of 4,000 patients. But that's not the problem. The problem is, what happens to those other 3,000 patients? Where do they go?
They're out in the cold.
They're out in the cold. And is he going to cherry pick? I'm sure that most doctors won't. But there will be doctors that will cherry pick. They'll want to take care of the best patients so that their outcome data will look good compared to their colleagues.
Well, this just goes to show us that the government really doesn't know how to run these programs,
Not at all.
and it has to be shifted more to the commercial side and to the free enterprise side if we want to see any real progress being made. You know, we're the last in the nation ranking for the number of primary care physicians per capita and have a chronic shortage of physicians and healthcare professionals, especially in our rural areas, even though this has been one of the largest, if not the largest, growth in jobs for Idaho. The governor says he is excited about the new osteopathic medicine college that will begin classes in August. Do you think that this is going to solve our problem with our shortage? And we don't even have a place to put most of these interns when they graduate, as I understand it.
Well, first of all, I'm very happy that we have the new osteopathic medical school, but I have concerns. The first number is they want to, I believe, graduate 150 doctors per class, if I'm not mistaken.
Right, that's right.
And so with just that in mind, I'm concerned about the amount of clinical pathology available to the medical students in order to learn how to be doctors. There's not that many sick people for 150 people per class. I went to Ohio State and we had 110 in my class, and there was a town of almost 2 million people then, and we had plenty of sick people to take care of. So that's one concern. The other concern is the fact that many of these medical students will do their internships and residencies in other locales.
Are we talking about foreign countries or here in the U.S.?
No, here in the U.S. And they will do that because they will be exposed to a greater number of patients who are sick. So if we just get 25 or 30 out of that class of 150, that would be a good thing, and I'm excited about it. But the same thing I said about the medical students could apply to interns and residents. We're expanding the number of interns and residents in this state significantly. I think Eastern Idaho Falls has asked for, I believe, 7. Blackfoot has asked for 6. Pocatello has asked for 3 to 6. I forget which. That's all good, but I'm concerned that if you got 6 residents per year group in Blackfoot, is there enough sick people in Blackfoot for them to learn how to take care of sick people?
We're going to have to wait a minute to find that out. We have to take a quick break. We'll be back in a few minutes. You're listening to Health Conclusions, brought to you by Altrua Health Share, with your host Bob Neugebauer on 580 KIDO AM and 107.5 FM. Welcome back to Health Conclusions on 580 KIDO AM, 107.5 FM. We're speaking with Dr. John Livingston, sponsored by AltruaHealthShare.org. And our conversation tonight is about Medicaid expansion. So, Doctor, continue on. We're talking about not having enough patients for doctors in a place like Blackfoot when they want 7 more doctors.
I recently spent a lot of time at the hospital in Blackfoot, and I was blown away at how big and how good and how competent the people working there were. I had no idea that Blackfoot had such a hospital. So my mother-in-law was at the hospital there, and so I was impressed. But I am concerned that it's not just the number of residents that's important. It's the amount of pathology that's available to them so they can learn. And it's not in their first 2 years of training, in the basic science years. It's in the clinical years that I'm concerned about. But I don't think the solution to the manpower problems in healthcare are necessarily to be found in the MD or osteopathic medical community. I think there's tremendous opportunity to utilize the talents of family nurse practitioners and physician assistants and other providers, physical therapists, radiation therapists, radiation technicians. We have a tremendous opportunity to leverage a workforce that is not necessarily all physician oriented. I think in the rural, a couple things. The first thing is we should licensing requirements by the State Board of Medicine, like South Dakota and several other states. We should enter into compact agreements with other states so that physicians can come from an outside state into Idaho for a period up to a year and apply for their license in Idaho while they're practicing in Idaho based on their home state license, so that they can be up and running and starting clinics and not have to have a year between jobs to start their practices. These are called licensing compacts. And I think that they would be terribly important in getting more people here. I think we should increase the clinical scope of practice of PAs and family nurse practitioners. And this can be done not necessarily through a licensing process, but through various mechanisms like telemedicine and things like that, where they could work in conjunction with a physician in a larger city, but still themselves be in a smaller town providing primary care. The one place where I've changed my mind about the healthcare delivery solutions offered by the SHIP system is I am a big proponent of direct primary care, but I don't think direct primary care should be run by a government entity housed in the Department of Health and Welfare. I think direct primary care should be part of a free market solution. And I think that even in Seattle, there was a direct primary care system that dealt exclusively with Medicaid patients. And they did it at a profit. And they were able to function until, after a period of 3 or 4 years, they had to be run down because the State Department of Health and Welfare in Olympia decided that they wanted to run a SHIP system of their own. And it's just those type of interventions by government agencies into the private market that destroy new ways of handling our healthcare delivery challenges. And so I would hope that we could develop incentives for direct primary care for Medicaid even that would not be housed in the Department of Health and Welfare but would be part of the free market.
Let me throw something at you here. You know, I gave you some material to look at for integrative medicine. I know it's something kind of new to you. But if you really want to do something about solving the shortage of physicians and healthcare professionals moving into integrative medicine and making use of all of the various naturopaths, chiropractors, alternative medicine, healthcare professionals, and put them to work, since they are now being required to be part of an integrative health group at hospitals to be used for chronic pain if they want good ratings. I guess maybe that's too simple of a solution, or it's, as you talk about, nurses and PAs. I'm saying you could expand that even further through licensing also.
So, again, I'm not a big fan of licensing. I think any license, whether it serves a community good type of purpose or not, no matter how you look at a license, it's a barrier to entry. It limits the amount of supply, and the supply curve shifts up and to the left. And as soon as that happens, prices go up every time. But when I was an intern, there was so much of what we did that are now being done by professional technicians, nurses. For example, when I was in internal medicine, I had to run my own blood counts. I did my own urinalyses. I had to read my own x-rays. When patients were operated on, I had to be the one to do their respiratory therapy. I had to be the one to walk the patients, to do their physical therapy. It was the doctors that did all that. And we rapidly, in the orthopedic surgery community, were the first to come on board with this. They found that they could do more. They could spend more time in the operating room taking care of sick patients if they delegated a lot of those other responsibilities. And in fact, patients were taken care of better if they had professional respiratory therapists, physical therapists, x-ray technicians, laboratory technicians. And this all occurred in the mid-'70s. So I think we can extend that today. I think that there are people in the community, not in the hospitals, but people in the community with expertise. And these would include chiropractors. These would include nutritionists. These would include naturopaths. The problem I have as we move forward in this direction is the single biggest commodity that the healthcare community has to offer patients is hope. And I have seen it over and over again. I remember when we started the Health Insurance Exchange, we had people in the audience that were crying because they felt that this was the solution to all the problems of healthcare. And they would come up and they would be crying, we gave them false hope. And that's wrong. We have to keep our expectations real. And and we have to be very careful. It's problematic when a nutritionist or a naturopath offers a cancer patient a cure, or the alternative may be fine, but we have to be very careful we don't offer solutions that are false hope to patients.
Well, I think that's why it's so important to integrate the allopathic along with the naturopathic and chiropractic services that are going to be available, but they need to work together to find the optimum way to work with a patient and find the best science-oriented way to deal with it. I don't think any one person should be able to do that, but it should be a consultation where you get all the best people talking about how to fix something.
So as far as the realm of, and this gets us now into the discussion about preventive medicine, wellness,
yes,
and overall medicine. And so I went to medical school in the late 60s, early 70s, when the public health movement first was getting its start. Remember that Medicaid and Medicare started in 1965. And the emphasis started going from taking care of sick patients to keeping people from being sick. And then, so there's no question that there's a role for public health. Having clean water, clean sewage that's away from the water source, clean food to eat, vaccinations, public health strategies, and taking care of communicable diseases. Extremely important. But what I see happening today is that the public health sector, especially with the Obama administration, has gotten the ear of the people at CMS and HSS, and they have forgotten that there has to be a way to take care of sick people. And we can't be taking care of the funds for taking care of sick people. So let's just go back to this whole idea of integrative medicine. I think, in my case, I'm 67 years old. I'm constantly trying to lose weight. The single biggest practitioner that is helping me stay out of the doctor's office is my gym trainer at the YMCA. And I have a Medicare Advantage health insurance plan that gives me a free membership to the YMCA.
Well, let's hold on a second before we get into an exercise program. We're going to have to take a quick break here. We'll be back in a few minutes. You're listening to Health Conclusions, brought to you by Alchua Health Share, with your host Bob Neugebauer on 580 KIDO AM and 107.5 FM. Welcome back to Healthy Conclusions on 580 KIDO. We're speaking with Dr. John Livingston, sponsored by AlchuaHealthShare.org. And our subject for this evening is Medicaid expansion and how we're going to solve this intricate problem of keeping government out and getting private enterprise in. So we're talking about the integrative care and how we can combine the different efforts of different practices to basically do better in terms of serving the people and getting them well, because I think wellness is the most important thing. How do we get people well? How do we keep people well? How do we incentivize them to do that? And how do we incentivize the physicians and doctors to encourage them and tell them how they can do this?
So, as I've gone through this journey of being on the health insurance exchange, the governor and Director Deal and Director Armstrong have given me carte blanche to their shops, and I've gotten to look at actuarial data and everything else. But I started doing a lot of reading, and one of the books I read was called The Healthcare Divide by Stephen Montmont. And Dr. Montmont was the former head of the British healthcare system. And he's a knight now. I guess he's Sir Stephen Montmont or something. But one of the things, and he's very liberal. He's not a conservative like me. But one of the things that he said that rang true with me is the fact that the conditions that people live under determine more about their health than what their health is that determines the conditions that people live under. So we've spent all our money and all our time spending money on various welfare programs trying to bring people up. The point of his discussion is, until people take control of their own lives and participate in the decisions that will make their life better and have ownership of those decisions, there's nothing the Public Health Service can do in England or in Sweden or Iceland or any place that will change the calculus of the number of well people and sick people. So if we gave gym memberships to 100% of the people on Medicaid, what percentage of those people would go to the gym 3 days a week?
Zero, unless you incentivize it.
So if you did that and you said, I don't know, we'll give you $50 a week if you go 3 times a week.
Or how about saying that if you go 3 times a week and you actually prove that you're getting better, we might consider giving you some more money on a SNAP program so you could buy organic food.
Don't get me going on SNAP, please. So the point is, I'll give you the greatest story that I have in my lifetime, in my experience, of integrative health. The first patient I ever took care of when I was consulted in the ER when I came here in June of 1988 was a 65-year-old man with Down syndrome. He had gray hair, he was starting to get bald, and he'd been taken care of by his mother and father, who were both in their mid-80s, for his entire life in Emmett, Idaho. Now, today, in a big city, this man would have been institutionalized at great cost to society. And so he had a gangrenous gallbladder, and I had to do an operation on him. But I got the story that his entire life in Emmett, he lived on a farm. Every Tuesday, his mom was given 4 hours of free time to go shopping and do errands by the ladies of their church. And every Thursday, she had 4 hours. There was a 5-person bridge club. And every week, one of the ladies would take care of this patient with Down syndrome at the farm so that his mother could play bridge. That is an example of integrative medicine. Who was doing the integrating? It was the people of the community. It was people taking care of each other. It's the ultimate form of charity. And that man was 65 years old, and except for his gallbladder problem that night, he was in great health. If he had grown up in a big city today, he would have been institutionalized, and he probably wouldn't have lived to be 65. So people taking care of themselves first and their neighbors second is the greatest form of integrative medicine that I can think of.
Well, you know, it's always good when you have a community of care like that. But I know we're not going to find that very much anymore. We may find it in some of the rural areas, but not in very many nowadays because of the government-sponsored healthcare system that we currently have. So there's no real need for people to do a lot of that. They just go to the government for the money, and hopefully they get taken care of. But when I look at the cost and the extensive studies I've done on integrative medicine over the past 2 years, almost every survey I looked at, done by numerous medical entities and insurance companies, integrative care is between 10 and 30% less costly than traditional care. And in most cases, it's more efficacious because the people who are involved in it are actually trying to get those patients healthy through nutrition, through exercise, through the various different methods that we all know work. Because the basic problem isn't that they're sick, it's because they allowed themselves to get sick. And you have to change that with the person themselves. I don't disagree. People are brought up in a different way than I was when I was a kid. You know, you eat differently, you have more prepared foods, more processed foods. There's more toxins in the air. There's something like 800,000 toxins that we breathe in every day. But you're not going to change all of that overnight. This is going to be a process. And I agree that we're going to have to change the process. So how do we entice more physicians, number one, to come to Idaho to practice, but to settle and work in rural areas where we really need some of this primary care. And do you think that a state like Idaho is capable of changing the way they do business and bringing the various participants in practitioners into the service to help these people, rather than putting the burden just on the doctors?
So I agree with everything you say, but let's take a look at what's happening. Idaho is the fastest growing state, in the country. It's almost half of the population of Idaho is in Ada and Canyon counties. There is no physician shortage in those counties. In fact, I can argue that we probably have more orthopedic and neurosurgeons per capita than most places in the country, including New York City. We have 64 orthopedic surgeons. We have 18 neurosurgeons. We have over 40 cardiologists. We have plenty of doctors in our most populated 2 counties.
But none where we need them.
That's right. So again, I don't think the solution is a physician in every town. I think we need to have PAs, family nurse practitioners, and other healthcare providers providing services in the rural areas. That's what the solution to that problem is. And I think, and I don't know the numbers, but I'm going to look it up by the end of the day, what percentage of students graduating from the PA program at Idaho State University stay in Idaho? I bet it's a pretty high number. I bet it's over 50%. And if that's the case, if you get 50% of your PA students staying and only 20% of your doctors staying, I would say that the way to go is to expand your PA student programs instead of trying to expand your number of residency slots.
Well, that's a pretty big change from where we're going right now, I can see.
Oh, yeah.
I know because my granddaughter is a PA, and I got a second one that will have her PA in July. One wants to stay in New York to work with oncologists, and the other really enjoys working here but wants to get back into the family practice. Now, that's quite a difference because she started in an ER room. So now, looking at what she's doing, she wants to get back into helping people, but from a family orientation. And I think that you're going to find a lot of them that would do that, should you be able to encourage the state to allow that to happen.
Well, she's done it perfect, because I used to have many PAs, maybe 20 or 30 that rotated through my service. And I always recommended to them that their first 2 years out of school, they do something either in the emergency department or in the operating room or in the ICU, or work with somebody that's doing a lot of emergency medicine, like a neurosurgeon or a cardiologist. And then after those 2 years and they've gotten their exposure to acute care, that just rounds them out to the point where they can practice anywhere.
Well, I agree, and I think she's done a heck of a job and is enjoying what she's doing. By the way, she wants to thank you for your help in advising her with some of the more intricate things of getting into the PA business, and it is a business in many ways. Thank you for joining us this evening and offering us insights on Medicaid. This is Bob Neugebauer saying good night for Health Conclusions. We hope you will join us again at the same time next week for another hour of informative talk on nutrition, exercise, and alternative medicine options. Sponsored by AlchuaHealthShare.org on 580 KIDO AM and 107.5 FM.